So mainly in history and examination, we've seen that thyroid swellings either come with frank lump or thyroid swelling, which can be either nodular swelling or it can be presenting with, or it can be a diffuse enlargement of thyroid. Also, patients can present with features of hypo or hyperthyroidism. Now, these both things can exist in isolation or together also. So these are two main starting points. Uh, Now, why we need to do what are the questions in our mind whenever we have a thyroid nodule or hyperthyroidism features? So we want to know in our workup whether the swelling is benign or malignant. That is one thing. That is very important. So, do we need to do FNACs? Do we need to do any functional analysis or not? So that's why we need. That's a main question which is there in our assessment. Second and first thing is about benign and malignant. Second thing about whether they are hyper functioning or hypofunctioning. These two are the most important questions. Also, the questions can be around whether there is any local pressure symptoms uh, causing to the nearby organs like trachea, like nerves, like esophagus. So all those things is what we want. So we do something called as a quadruple assessment. Now we have seen triple assessment at many places, like in breast and other places. So we basically add one more thing here. So functionally, it is the same thing. So it has a clinical and function examination, that is one, imaging, two, and cytological or pathological evaluation, which is three, which is same as the triple assessment in most other diseases. We just add one more parameter, which is functional analysis, which is in the blood, which is in the form of the thyroid scans and other things. So we'll talk about all these four basic modalities, which has to be done in all thyroid swellings at least, and also in case of hypothyroidism. So some adjuncts which are important rather than just these things are the sizes of nodules. So we can size the nodules. The role of genetics now, especially BRAF and RAS, some mutations, especially for malignancies. We have thyroid isotope scanning, and also there's a role of calcitonin measurements. So these are some adjuncts, but you can see they also fit into some or other parameter of quadruple assessment. Now, we have done most of it. Just to revise, history-wise, we talk about duration, size, compressive symptoms. We talk about function status. We talk about past history of any risk factors like irradiation and other things. Age also is a factor because less than 20 and more than 70 are high risk for us. And male gender is a high risk for malignancies. And if there is any family history. Also, when we examine various techniques. Mostly it is examined from the back and with neck mild extension. We notice the size. We notice whether the nodule is solitary or it's a multinodular goiter. Now, whenever we see a big nodule, it can present in two situations. Either the rest of the gland is absolutely normal, then it's called STN. And if the rest of the gland is also nodular, it's a picture of multinodular goiter, and then one nodule is very big, it's called as a dominant nodule. So these two things are a little different. In STN, the rest of the nodule is absolutely normal, at least on examination, and then we can evaluate that. So nodules that are firm and hard or they're fixed to surrounding structures can also be malignant. So we look for the relationship of the nodule with the surrounding tissues. And so we look for cervical lymph nodes, and we look for vocal cord mobility using a laryngoscope. So these are the various conditions by which patient can present. Either it can be diffuse thyromegaly, which in presence of hyperthyroidism can be Graves' disease. It can be STN or it can be dominant nodule. I told you the difference. In STN, the rest of the gland is normal, and it is in picture of MNG or multinodular goiter, or a patient can present with multinodular goiter as such. Now, remember one fact that when we feel the gland on clinical examination, if we are finding a STN or solitary thyroid nodule, on ultrasound, most of this, at least it says 75% of these, will turn out to be multinodular on ultrasound. And after on histopathology, further 75% of the STNs on ultrasound will also be MNG. So a true STN is very rare. This is what you should remember. So that's why even in STN, many surgeons will say that we need to do a total thyroidectomy, especially if the risk of surgery, risk of malignancy is very high. So remember this.